Yeah, so the Center for Connected Health Policy just recently released this. I believe it was actually only yesterday that it was released, outlining some of the changes for this coming period. So I'm going to highlight a couple of these as we go through. Is there anything in particular that you are interested in the fee schedule? That way I don't go through kind of all the changes, but if there's particular ones that you're interested in.
So I serve FQHCs pretty exclusively. So
Yeah.
that's my focus, specifically more the telehealth stuff. I know I haven't gotten through the final rule yet. I read through the proposed rule, but I haven't made it through final rule yet.
Yeah, there is a specific element for FQHCs in here. I just need to find it. And one of the big things, especially for your FQHCs that are doing telebehavioral health services, is one of the big changes with this new fee schedule is they're eliminating that geographic barrier. And so it takes away a lot of that concern that any of those restrictions would return after the course of the public health emergency. So that's a huge win for telebehavioral health, as well as, alleviates any of the concerns that people may have with being able to provide that care to patients at home. And I think that's actually what it's saying here. So FQHCs and RHCs are eligible to provide mental health services. Oh, it's also audio only when the patient is not capable or if does not want to use live video. They will use the 9.5 modifier for live video interactions, and a new service modifier will be created for audio only. FQHCs will also be subject to the same 6-month in-person visit and subsequent 12-month in-person visit requirements that were required by the CAA, though limited exceptions are made for the 12-month in-person visit. This in-person visit is only required if the patient is receiving services in home.
So they have to have, prior to starting telehealth, they have to have had an in-person visit in the last 6 months, right?
Correct. Yeah.
And then they have to have another visit in person at some point in the subsequent 12 months after the first telehealth.
Yes. Yeah. And as far as I'm aware, that is, it doesn't matter the diagnosis. That is kind of the rule, kind of across the board. So yeah, that initial visit and then the 12 after they've had that initial visit have to have at least one in-person visit 12 months after.
So you're saying the diagnosis code doesn't matter, but does the line of service matter?
So the modifier will. So if it has the modifier to where that patient is receiving that care at home in a direct-to-consumer format, that is where that particular restriction will apply, or that particular policy will apply.
But does the in-person visit have to follow the same specialty of the behavioral health?
Oh, that's a good question. I'm not sure. I might have to look at the more detailed version to see if they stated anything specific about what is required in that in-person visit.
I was on another call. I got the feeling that that's what I kind of gathered from what they were saying, but.
Okay. Kelsey, do you want to drop your email into the chat?
Yeah.
Luke and I can look into that a little bit further and see if we can find more details in the full version of the fee schedule. And I wonder if they don't have it in, because I believe the full published version comes out, is it the 18th in a week? So if we don't find it in the kind of unpublished version, maybe we'll find it in the published version next week. Other notable, the audio only, we kind of talked about that briefly. So that's now for mental health specifically, is something that can be used for the treatment and evaluation and diagnosis of mental health. Here are kind of the general criteria for that. So it does fall kind of what we were talking about here, but that the home does have to be the originating site. And the provider must have the capability to provide live video, but the patient consents to receive the audio only. Outside of that, I think this is mostly just going into a little bit more detail with that, but that's kind of the very, big picture, the main things for the FQHCs that came out with that. There were some things that came with RTM, if any of your FQHCs are involved in any of that in any way, shape, or form. And then also for principal care management and chronic care management. So there's a few changes in the codes for those as well, if any of your FQHCs are in there.
We bill a different code for chronic care management, principal care management, and general BHI, but it still kind of changed. It changed how they're figuring our rate for it, but.
Right. But these changes didn't impact it too much.
Not in the way it would with a regular provider.
Right.
Can I find this document online?
Yeah, and actually, since I have your email, I can actually just email it to you following this call so that you'll
Perfect.
have it easily.
Perfect. That is great. Thank you.
No problem. Is there any other questions you have for us, Kelsey? Since
I was just gonna say,
right now you're our sole focus. So any other questions you have for us, go ahead and shoot.
That's all I have today. I think on telehealth, I'll just share that we've got a couple of challenges in Michigan specific to our Medicaid program and specifically the crossover claims. But we're working on it. So I'm hopeful that this change in this implementation will make things slightly easier for our FQHCs in Michigan.
Right. How many FQHCs do you work with?
I think our membership is 43. Some of them are THCs as well.
Okay.
I think our membership's at 43, right around 40, something like that.
Okay. Yeah, that's a lot of different facilities to work with.
It is. I have I probably regularly, some of them are, they'll kind of all go in and out a little bit as far as how much they contact me and how much I talk with them. So regularly probably talking to 20, 25, something like that. And then,
okay.
There are people who I talk to every 6 months and people I talk to every week. So
sure.
Just depends on the health center.
Right, exactly. Yeah, you have some that are frequent flyers that will come through all the time. That's great. Kelsey, I don't know if you've seen before, but we actually do have some resources that are specific to FQHCs. If you are interested in some of those resources, we have it both the UMTRC as well as the UMTRC is part of a national consortium of telehealth resource centers. And we are dropping a lot of content related to FQHCs. So if you're interested in that, I can send you that whenever I send you the email. Some of the stuff from the national consortium, we may not have yet, but it will be live very soon. So if that becomes available, I'd be happy to send that to you as well, especially if you're working with 43 different FQHCs. I think that will be helpful for you.
Yeah, absolutely. Feel free to pass that along. I'd appreciate it.
Yeah, awesome.
All things telehealth in the last 18, 20 months or whatever. So
yeah.
Appreciate any insight.
Yeah. Do you feel that for a lot of your FQHCs, it was relatively painless to, be able to implement those services, or was it really, really hard for some of the FQHCs?
I think we had people kind of on all ends of the spectrum.
Yeah.
We had quite a few who had kind of been like kind of dabbling in it because our reimbursement wasn't, for Medicare wasn't there, and
Right.
Medicaid reimbursement wasn't. We'd been working on it for quite a while, so or I should say the PCA did. I was not actually at the PCA when they kind of had started that, but they had been working on trying to get policy from the state for, the Medicaid patients. So luckily, because the PCA had been working on that prior to the implementation, or prior to COVID, they implemented that policy quite quickly once once it was clear that we were going, we were headed towards a pandemic.
Right.
That policy out straight away, and we're pretty good to go with it. There was no comment period, it wasn't a proposed policy. It went from, something that we knew was happening on the MDHHS side to policies out and everybody can utilize it. So,
right.
In that sense, it was really good as far as like getting people up and moving with like an actual technology platform and all of that. That took a little bit longer.
Sure.
And we'd also been working on, as a PCA, we'd also been working on like a communication platform for our members to use to like text message patients and that.
Oh yeah.
Yeah. And so, so we'd been doing that prior to COVID happening. And then of course, COVID happened, and some of the health centers decided to kind of move that, because they all of a sudden had the availability to do telehealth through that program as well. So some of them utilized that. Some of them initially took advantage of the ability to use, the Facebook Live, or not Facebook Live, what's the direct messaging platform on Facebook? I can't even right now.
Oh, Messenger.
Thank you. And like the FaceTime with the iPhones and stuff. I know some of them.
Oh, that's great. Yeah.
A couple of those things kind of early on, but I think everybody now pretty much either has like a telehealth platform, HIP and all those things. So I think we're at a point now where everybody's kind of on board.
Yeah.
But some of them were pretty close to, ready to go. But we had a lot of people put in, implement policies and procedures quite quickly. And
yeah,
we at the PCA did a lot of like peer-to-peer learning type opportunities for them. So.
No, that's great. Yeah, that's a lot of, we've gotten feedback from lots of people that, yeah, there are some providers that were able to get up and running really quickly, some that this was really difficult for them. But it sounds like for a lot of them that it was relatively smooth as something like this could be. But and that they were, adapted it pretty quickly. Kind of curious for some of your FQHCs, have a lot of them, we've had some interest in direct-to-consumer primary care. Behavioral health has been kind of like the big thing of the pandemic that everyone is all in on, direct-to-consumer behavioral health. Direct-to-consumer primary care, at least from some feedback from providers, has definitely started to decline since people can come back into the office. I was curious, just with some of the FQHCs that you work with, are they still offering it through a direct-to-consumer format, or once people were able to get access to the vaccine and start coming in more regularly, if people were preferring to come in versus go that route?
So outside of behavioral health, because that has maintained a pretty high level of like telehealth, and like personally I have people who I know who are doing their behavioral health via telehealth because it's convenient. But outside of behavioral health, we did see a pretty significant drop off in the amount of telehealth that was getting done. We actually initially saw a drop off, I think last summer, probably like mid to late summer, as things kind of has like, as the flow of the pandemic had gone down.
Right.
Excuse me. But then, as things kind of went up, and being in Michigan and flu season and all that, I think telehealth increased a bit over that period, but I don't, again, with the summertime period and now the vaccines but I think most of them still plan to use telehealth when they can,
Right. Yeah, it's just interesting to see. It's different based off of geography, state, also the type of provider that's providing the service and the type of patient. So it'll be interesting to see once we, get into next year or 2023 to see what some of behavioral health is going to stay. And that one, no one doubts like that modality of telehealth. But I am curious with the primary care piece, just because there are other aspects of like telestroke and teleneurology that are going to remain really strong outside the pandemic. But for primary care, where there are sometimes you have to come in if patients will still be interested in receiving it through that direct consumer format. So that's why I was curious and asking. Definitely have heard kind of a variety of feedback on that. So I hadn't heard from someone directly from Michigan though, so it's good to hear.
Yeah, I think our rural centers will probably, I don't know. But I think as I'm saying, and I'm like, well, maybe not, but like, the rural health centers, especially like up in the UP, where like access is just, 45 minutes to
yeah, absolutely. Yeah.
Like I can see that being a bigger thing. But at the same time, sometimes I think, depending on your patient population, if your demographic is older, then maybe not, because doing, an in-person service.
Yeah, absolutely. That's interesting. Oh, I'm sorry, Kelsey, I'm asking you more questions than what you came to ask.
Oh, no worries.
Yeah.
No worries. I appreciate the info on the physician fee schedule. It's it's really exciting to be able to have the opportunity, because all of this has been pending a public health emergency. All of our allowances are pending.
Yeah, absolutely.
So having something that we're going to have, at least beyond the public health emergency is pretty exciting. And
absolutely.
And a little scary maybe too.
Yeah. No, it is a huge win to be able to see, these were policies before the pandemic that were really, really difficult to move. And to be able to see that, the needle has moved this much in this short period of time, it's really amazing to see. And that we have, like you said, there are certain things that we know absolutely outside of the public health emergency, we have this. And so regardless of, where reimbursement swings, we have these particular avenues that we can still provide these services to patients without having some of those other reimbursement barriers or policy barriers that existed before the pandemic.
Absolutely. It's exciting.
So Kelsey, I have your email. So I will follow up with you on the fact sheet, as well as I will look to see if we have some of those FQHC resources available. If not, I know it will come out in about a week.
Okay.
And I'd be happy to send those to you as well. So
appreciate that. Thank you.
Absolutely. Well, Kelsey, if you don't have any other questions, we'll go ahead and close for now. But thanks for joining us, and you'll see an email from me shortly.
Awesome. Thank you. Welcome, Cameron.
Thank you, Kelsey.
Bye.
Bye.